Well, hi, everybody. Thank you very much for joining us for the fourth part of our five-part webinar series on clinical accommodations. Today's presentation is called Student Voices, Medical Student Perspectives on the Clinical Accommodations Guide. I'm Suchi Rastogi. I am the CEO and co-founder of the Disability in Medicine Mutual Mentorship Program, and I'm going to be your moderator for tonight. And our wonderful panelists are Pepper Sear, Zach Khalil, and Nora Newcomb, who are PGY1 residents from the organization Medical Students with Disability and Chronic Illness. I'm going to start off with a little bit of context to explain how today's presentation fits into the broader arc of the Clinical Accommodations webinar series. So across this series, we've been moving deliberately from evidence to tools and then finally to practice. So the webinar series features a resource, the Clinical Accommodations Guide for Disability Inclusive Undergraduate Medical Education. Webinar 1 focused on a Delphi research study that underpins the Clinical Accommodations Guide. Webinar 2 focused on the guide itself. Webinar 3 examined how faculty and administrators could implement the principles in the guide. And all three of these webinars are on the Docs with Disabilities YouTube channel. So please do check them out if you would like to learn more. And we will eventually be dropping the links to those into the chat. Today's webinar, the fourth one, is going to extend the work explained in the first three webinars by examining the medical student perspective on things. So our panelists, Pepper, Zach, and Nora, were themselves clinical phase medical students navigating the accommodations process while they were helping to craft the language for the accommodations that went into the guide. And so tonight they're going to share their perspectives on the strengths and limitations and applications of this resource for medical students with disabilities. In the fifth and final webinar, which is coming up on March 5th from 12 to 1:30 p.m. Eastern Time, we're going to have a workshop where participants are going to be invited to create processes for their academic programs. And so if you happen to be involved in the overall broader process of creating infrastructure for your institution, I really highly encourage you to take part of this exciting opportunity. Okay, so now zooming into today's presentation, I'd like to share our learning objectives for the evening. By the end of this webinar, you should be able to first recognize the barriers and facilitators that medical students with disabilities experience when attempting to access and implement their accommodations during clinical training. Second, identify practical examples of how standardized accommodations language can support medical students with disabilities to self-advocate and to optimize their learning in partnership with institutional actors. And then finally, explain why it's essential to meaningfully include medical students with lived disability experience when creating resources to advance disability inclusive medical education. So I'm going to spend the next maybe 7 minutes giving some context, and the first bit of information will be about how disability accommodations work during clinical medical education. So normally, learners with disabilities access accommodations by engaging in an interactive process with institutional representatives. Ideally, this involves an iterative and informed conversation, or a series of such conversations, first between the student and their disability resource professional, or DRP, as it's read on the slide. And then the DRP has another conversation with relevant clinical faculty or program leadership. And there are continuing cycles of these conversations until access needs are met in such a way that the full rigor of clinical training is preserved. But in reality, at least 20% of medical students with disabilities don't request accommodations, so they don't even begin the interactive process. And then when the interactive process does take place, it often functions suboptimally for a few different reasons. The first reason is that many faculty and disability resource professionals lack experience with accommodations that are specific to medical education contexts. The second reason is that there's a lack of standardized language in accommodations letters, and that creates confusion for all stakeholders. And finally, guidance on how to implement these supports in clinical settings is often vague or inconsistent. So, to address these barriers, the Docs with Disabilities initiative partnered with medical students with disability and chronic illness, the Disability in Medicine Mutual Mentorship Program, and the Stanford Medicine Alliance for Disability Inclusion and Equity. And together, these organizations published a Delphi research study in the journal Academic Medicine. The study tabulated a list of 75 example accommodations for clinical phase medical students that are actually used in US medical schools, plus standardized language used to articulate them. So our panelists were among the then clinical phase medical students included on the Delphi committee that vetted this accommodations language. And tonight, they're going to share their perspectives about this language and their roles in helping to shape it. As an aside, if you want to read the research paper, then either scan the QR code on the right side of this slide, or you can navigate to the link that we will be dropping into the chat. And if you want an in-depth explanation of how the accommodations language was developed, I also highly recommend that you watch the first webinar in the webinar series, which is on the Docs with Disabilities YouTube channel. Additionally, the organizations I just mentioned created a companion guide to clinical accommodations in undergraduate medical education. And so, in addition to including all 75 of the accommodations produced by the Delphi research study, the guide provides framing on the interactive process, the legal foundations for the accommodations process, and further guidance on how to write and implement accommodations letters, and much more. As is apparent from the right side of the slide, many people were involved in creating and vetting this guide, and that included disability inclusion experts, DRPs, and clinical phase medical students who were all involved in the Delphi research study. Pepper, Nora, and Zach were part of this too, and tonight we're going to explore their insights about what this guide means for students. You can download this guide for free, by the way, on the Docs with Disabilities website using the QR code on, it's sort of on the left side of the slide in pink. Or you can click on a link we're going to drop into the chat for you. And additionally, for a deeper dive into what the guide offers and how it might be used by faculty and administrators and DRPs, you can check out the second webinar in our webinar series, which has been posted on the Docs with Disabilities YouTube channel. Now, as our panel discussion unfolds, I'd like you all to keep a few caveats in mind about the accommodations guide. So the guide isn't meant to be a prescriptive checklist or rule book, and the 75 accommodations that came out of the research study aren't meant to be plug-and-play options that could be applied without going through the legally mandated interactive process. So instead of replacing the interactive process, these resources are meant to clarify and streamline it, and they're meant to illustrate what might be possible for clinical accommodations in undergraduate medical education. And they're also meant to reduce misconceptions and miscommunication between all the stakeholders involved in the interactive process. So I hope that was clear. A few final housekeeping notes before we get to our panel. So for the next half hour or so, the panelists and I are going to have a moderated discussion. During that time, please feel free to drop your thoughts into the Q&A panel. So there's a Q&A button in the bottom ribbon of your Zoom window. And you can especially feel free to include future resources that you want to see our organizations create. Also, the panelists are going to devote about 20 minutes to answering your questions at the very end of the webinar. So to submit your questions, please also enter them into the Q&A panel. And keep in mind that you can submit your questions there anonymously. And as an aside, I'm not going to be monitoring the chat feature as carefully as the Q&A panel, although I will try my best. But if you have thoughts that you really want me to see live and respond to live, then please put them into the Q&A panel if you can. All right, guys. So with that, I am thrilled to get our panel started with Pepper, Zach, and Nora. So I'll stop sharing now. All right. Um, So, panelists, I'd like to first ask you if you could introduce yourselves. Pepper, would you like to get started? And please share your name, your stage of training, and your institutional affiliation.
Great. So, hi, I'm Pepper Sear. I'm a PGY1, that's a first year resident in the combined pediatrics and physical medicine and rehabilitation residency at Nemours Children's Hospital in Wilmington, Delaware, and Thomas Jefferson University in Philadelphia.
Awesome. Zach, would you like to go next?
Sure. I'm Zach Khalil. I am a PGY1 transitional year student at Ocean University Medical Center. It's a Hackensack Center. And next year, I'll be starting anesthesia for an advanced program at Jefferson.
Awesome. And Nora?
Hi, I'm Nora Newcomb. I'm also PGY1. I'm doing a transitional year at St. Luke's Hospital Anderson campus in Easton, Pennsylvania, and I'm reapplying for physical medicine and rehabilitation residency.
Awesome. Well, thank you all so much for being here tonight. I really appreciate it. And I guess I'll jump into the first question. Um, First thing is, would you be able to describe your experiences or things that you've observed while watching others about the clinical accommodations process in medical school?
I can start.
Go ahead.
I mean, first things first, it's fraught. So I think clinical accommodations as a whole are an area that is misunderstood and approached, in my opinion, quite often with trepidation instead of like curiosity. I think that this stems from a few things. I think there's historically been a lack of medical students who have either needed or asked for clinical accommodations. I think it's more often that it was not asked for than not needed. And then when things are asked for, I think there's a bit of a struggle about who is the person who grants them. Because while it should be the DRP, most DRPs are not comfortable or not knowledgeable enough in clinical scenarios to create clinical accommodations. And unlike coursework, which all of us have had a decade plus of experience in, knowing what you're going to need in a clinical environment that you've never set foot in, the learner, it's very hard to do that. And so the learner can't add what they need to the same degree that they can for a classroom. And then whoever your other person is, student affairs, whichever dean works with the DRP at your institution, may feel that they're not a disability resource professional and therefore cannot grant accommodations. And then on top of that, there's the rules of the hospital and whatever ADA thing they have going on and whatever employee health thing they have going on. And so I think there's so many barriers and no one quite knows what to do that it's very hard to get things started and it becomes a fearful process instead of one where we can think creatively and curiously about how to best accommodate and best support a learner being the most successful version of themselves in their clinical years.
Yeah, and following up on what Nora's saying there, from talking to a lot of students, um, I feel like one of the biggest questions that comes up is what is even available? I feel like it's both an open, confusing thing for a lot of students about what could my school offer? What am I going to need? A lot of times students don't feel like they have a really good grasp of what is going to be asked of them on a really like nitty-gritty practical basis day to day in their clinical rotations until they get there. And then by then it's either too late or going to be just very difficult to get things implemented in time because as a medical student, oftentimes it felt like I was starting a whole new job every 2 to 3 weeks. And, it's quite common for accommodations processes to take far longer than that. But as a clinical student, if it takes a month to get this accommodated, well, by then I've moved on 2 rotations. And so it's something that was a really big challenge for a lot of people is what's going to be available? What am I going to need? And how the heck are we going to get that planned out before I'm there?
Yeah, I think to kind of build on that, the biggest thing that I saw was variability in this process as well, because in my limited experience, I had that creativity that Nora was talking about. I knew what questions to ask because I had people around me that have gotten accommodations before. And so it was easier for me. And I had a DRP who was willing to work with me, told me exactly what to write, how to write it, and who to send it to, and gave me the confidence to know that everything was going to be fine. And that, it's that kind of collaborative process that then translates to like a good medical education, right? Feeling as if you're in the driver's seat. It's not this kind of big mountain that you have to climb. It's the DRP or whoever, and obviously the people that support too, kind of helping you formulate a plan and feeling confident that you can execute it. Now, that was not the universal experience because I talked to students all over the country where they did not have that level of support. They did not, like kind of Nora was saying, that DRP was afraid of some of the clinical personnel scenarios, whatever. And so the biggest word that comes to mind about my experience was highly variable, which is one of the reasons why I like this project.
Yeah, that's really insightful. And kind of jumping off what you all said, I'm curious to know a little more about what you observed not working versus working when people tried to go through the process.
One of the pieces of advice that I give to people is to start early. I had the advantage of being an MD PhD student and therefore having a long period of time in between getting affiliated to the institution and having access to those clinical spaces and then becoming a clinical student that I was able to use to do things like I set up to go and shadow a third year med student on a few rotations to see where does she go? What does she do? What is expected of her on a day-to-day basis so that I could figure out what am I going to need? And a lot of people don't have the opportunity to do that. But I also reached out to each of my clerkship directors, a whole kind of clerkship and change ahead, so that we could go over my accommodations, make sure that they understood what was on there, anything that we needed to sort out ahead of time. Some things had to do with the way things were going to get scheduled or like location sites were going to be handled. And so again, starting early was very helpful for that. Um, but it's also important as you're doing that to think about the disclosure process and what to have it sorted out ahead of time. Who's going to disclose, what it needs to be disclosed, and when is that going to happen, so that you kind of have that figured out. So if the student doesn't want to, isn't comfortable, or it's not kind of the plan for them to do it themselves, they don't have to do that every 2 weeks and have this conversation over and over again. Or is it that's going to be done, through the DRP? Is it going to be done through their faculty? But just having a plan for that is another really important piece of this process.
And it can be, this is, I'm only saying this because I just did this last week for step 3, but it's a daunting process. That preparation really sucks for many reasons. Number one, it can feel bad to go through, kind of re-traumatizing yourself, having to read about yourself, write about yourself, say all these things. It's not fun. It's hard. So I just want to give that some words. But I think the most important thing, that kind of building off what Pepper saw, that I felt was preparation and thinking ahead about what I'm going to do with each specific rotation. Now, that was just for me, but I felt it nice to have a plan. So for the rotations that I knew were going to be ones that I would be more likely to require accommodation, I was proactive. I reached out to, who I knew I had to. And I sometimes I gave them my letter, sometimes I didn't. But I wasn't like, well, I'll go there and find out. I was like, no, I'm going to preempt a little bit. It's kind of, you have to do some, getting all the actual accommodation is important, but also thinking about, okay, how am I actually going to go about implementing this was important for me.
I think something that we're sort of touching on, but not quite, is finding your allies. And often you hope that they're your course directors. You hope that they're admin. You hope that they're your DRP. but it can be anybody. Perhaps your program has a surgical skills center, and there's somebody there who's an ally to you, and they'll give you time in the center to figure out what might work for you. Um, Perhaps it's the coordinator who makes the schedule. I'm not saying this to say don't go through proper channels, but I think what we're hearing here in building off of what Pepper and Zach are saying is none of this happens in a vacuum. None of this happens alone. Everything in medicine exists in very big groups, and changes aren't just for you. When a schedule changes, it's usually not just your schedule, and you never know what other dominoes are going to fall. So I think finding the people that are willing to show up with you early, help you figure it out, and then continually check in with you as you go through it. I think that process is really key to success because, like we've all been saying, you don't always know what you need till you get there. You can try and try and try, but you may not know. And so finding your allies, having those resources, having those people in your corner is key to not just initial, but continued success throughout clinicals.
Yeah, that really resonates with me too, given my own experiences once being a clinical phase medical student as well. And what I heard from you both, or from all three of you, was about a little bit about the mental and administrative burden for students. And then some examples of things that improved the process on your side, like what you had to do to make it better. I'm now curious to hear a little bit more or drilling down deeper into the dynamics of how the accommodations process and implementation played out um, on the ground, whether for yourselves or for classmates you might have observed. Um, Specifically, I'm wondering, were there limitations in what you or others were able to actually access once you had your accommodations supposedly in place? And I have another question after that, but I think I'll just start with that one.
Could I just clarify, what do you mean by access? I just want to understand it.
Yeah, so what I mean is, once you had your accommodations letter and it was written down, so in theory you were supposed to have access to X accommodation, then were there limitations afterwards in how that was implemented or whether you were able to get it on the ground?
I mean, I can start. Um, so something that we did that I thought was very helpful at my university, because I had both like clinical and classroom accommodations, is to create an approved truncated version of my letter that was meant to go out to people I was working with. And depending on the rotation, that was either my senior resident for whatever team I was on, or it was the attending. And so it would be something like, hi, you're getting this email because you're going to work with Nora. She has accommodations. Here's what they are. If you have any questions, please reach out to so and so. And it was never to me. It was never, if you have any questions, ask the student. It was always, if you have any questions, please refer to this admin person. And so that was very helpful because when I would start a rotation, my first thing would always be, hi, did you get an email about me? I think you might have. And it also gave me legitimacy because it allowed me to go in and say, your boss sent you that email about me. I promise I'm not lying. The issue then was not everyone knew about those emails in advance. It was usually at the beginning of a very busy workday, and maybe as a med student, I'd shown up an hour and a half into it because I got told to show up later than the residents did. And then it was sometimes put on the wrong person. And by that, I mean usually the senior resident who didn't know I was coming and had a bunch of other stuff to do. And on more like a floors-based rotation, something outpatient, it didn't matter as much. But for surgery, it meant that I was showing up with odd accommodations. Like I wear ring splints and I was supposed to have a sterile set. I was supposed to be able to like scrub in a certain way. Like it was very complicated. And I'd show up in the OR, sometimes meeting these people for the first time because I wouldn't know who they were because I would just get assigned and be like, hi, I have all of these accommodations and I'm weird about like, it's going to be like weird sterile equipment. And they would just be like, this case is starting in 10 minutes. I don't know how to help you. And so there were things that worked really well, especially when they were in my power to accomplish. But anything that was more systems based, I think that was something that was particularly lacking, and I think is something that's really hard to do, especially in places like the OR, because it is such a changing environment. You don't always know who's going to be there in advance. And so I think some things work better, some things were a little not as good, personally.
Unfortunately, I don't think that my answer can be universally applied, but if it does apply to you, that's great. One of the things that made the dynamics of my accommodation easier is I carried around a chair. I carried around a chair because I needed to sit sometimes. Um, many knee surgeries. So it was very easy for me to go up and be like, "This is my chair. I'm going to use this chair. I sent you an email. We're done talking." To be, it's much easier to be that way when you're a med student. I'm paying to be there. You can have not an attitude, but you can say this is, you don't have to be rude, but you could, it was easy because I had a prop, right? I had a thing that said, "This is my chair. I'm going to sit in it. Also, I'm going to get water whenever I need it. I sent you a letter about it." I wasn't always that direct. I would say, "Hi," introduce myself. Then they would ask about the chair. So, I didn't like them interacting with the DRP. That doesn't mean that that's the right move or the wrong move. That's just personally what I did. I liked sending it to them myself because it had the Jefferson letterhead. It was if they wanted to verify with the resource office, they could. But I felt that it was, I guess, I had less trouble accessing things mainly because I had a physical reminder, which is not always the case. And those are harder. I think that I believe they're hard.
Yeah, and I think also getting into that disclosure, legitimacy, and the process and pieces, I think that also gets into the idea of students having both, sometimes we'll have what we call formal and informal accommodations. So there may be things that you have that are approved, through all the channels and all the processes and, that you're required to be provided with. But there can also be things that students have in addition to or instead of those that are kind of just arranged within their team that are not, legally required on paper things, but that are kind of informally made to occur. And so, speaking as someone who some of my things were kind of done as a mix of kind of formal and informal things, I often would just present that in an email ahead of time. Usually, like the school often encouraged us to reach out to our clinical teams like the Thursday before rotations, just in general, not for disability specific, but just to ask, where do I show up on Monday? Do I need to prepare my own lunch? Like those sorts of things. And so just in that email, I would include, hey, here's, the things that I'll need from an accommodations angle. If you have any questions, let me know. I can provide. I would also say like providing my letter on request, and I'll be honest, no one asked me for it. But I did have it if they did. But it is something that, can be variably implemented. And also, as we talked about, just that turnover and the uncertainty, um, especially as a clinical student, you may not get your schedule until very far in advance. And so as much as we talk about like planning ahead and trying to do things ahead, sometimes that's not possible because you just found out that, oh, so-and-so's clinic got canceled. And so now you're getting moved over here today and you've got to rearrange and make that work. Um, and then while thankfully I have never had this experience, I have definitely talked to students who have had the experience of having accommodations that were made and approved and written out on letterhead that they were not able to get people to implement. And that does happen.
Yeah, thank you for that. That's, I think, going to be very helpful information to a lot of people. Um, I think I'd like to switch gears now and talk a little bit more about the accommodations guide. And so I was wondering, especially regarding the language and trying to come up with standardized language to articulate accommodations. What was it like for you guys to road test that language and see whether you thought it worked? And as a reminder for those in the audience, this is the language of the 75 accommodations that went into the research study and the guide.
I think it was a really interesting experience, both to see some accommodations that I could immediately relate to, things that were either accommodations that I'd had or things that were similar to those, or ones that about people that I knew, but also a lot of accommodations that I was less familiar with. As we'll talk a little bit more later about kind of who was involved in the expertise and also, limitations that expertise that we were able to bring. But honestly, it was really exciting, as we talked about before, that um, not knowing what was available has been a huge issue in the community for a long time. And so having, as we talked about, it's not a menu, but it kind of gives people a starting point of these are things that could be done. Maybe not exactly in this way, maybe not exactly, details for your situation, your institution, but at least a starting point would be really helpful. And it's also really helpful to look at that and see um, the way some of the things were written and to be able to revise those. There were places where um, language needed to be shifted a bit to be more specific, to be less specific. A lot of times, what we ended up doing actually was taking the bits in the descriptions that would have specified exactly how something was to be done or what equipment was to be used, and instead just put in brackets and say, the student will require access to these things, and in order to accomplish these tasks, to give the person writing this and implementing it a little bit more, leeway to give exactly how it's to be done to fit that student in that situation. Um, but it was really an interesting process to be able to really bring that real world perspective of knowing what does this actually look like in the clinical space, or what does this actually look like in terms of the expectations on medical students.
I think something that this process really drove home for me was the difference between disability and access need. I think something that we find a lot in medical education is that it really reinforces the social model of disability. We have inherent disabilities within ourselves, but then the way that the medical system works and the medical education system works is that it requires specific things of you. And if you cannot do it in a specific way, then you are disabled by the structures that exist. And so some of the things for accommodations are things that in normal life a person would be able to self-accommodate with. They would be able to bring in their own, assistive or adaptive tech, or they would be able to sit down, or they'd be able to go get water. The need to drink water is not in and of itself a disability. Like, that's not a radical statement. The fact that an accommodation is needed for it, though, speaks to access need. And it's a reframing. When we think about what goes in this guide and the language and the way we talk about it, it's all thinking about how do we make this environment better, not what is this person's disability and how do I build everything around it, but what is this way I can allow people with a variety of disabilities, like a written way to say, this is how you access this space.
Yeah, I think one of the things I thought about while I was looking at all these was kind of the concept of universal design and having curriculum that doesn't require all of these things. We don't have live in an ideal world, but that's kind of something I thought about. I was like, man, it would be great if this was just already, we're missing out on physicians that better understand the real patient population because we're kind of just automatically excluding them. The other thing I thought was, man, do I know a really specific amount about one thing, but then nothing about anything else? Like when there was one, I'll never forget, there was one accommodation that had to do with like bringing something to sit on in the OR. And I wrote like 5 paragraphs about, exactly how that could be implemented, why, and just like tweaking the language to make it universal. And then like I got to another one that had nothing to do with any accommodation I needed. And I was like, I have no idea what to write. I can't give feedback because I don't know. But so I guess both the variability and the sadness of, I wish there was something, I wish there was a curriculum universally designed.
Yeah. That's really, really helpful. And I'm specifically curious too about your reactions to some of the language and why maybe you thought like why the student perspective was uniquely important to shaping that language, especially compared to the other types of panelists who were involved in the process, like the experts or the researchers or the faculty.
I mean, I think since it kind of is what I was talking, I kind of just said it, or I feel like I gave the answer away. But I think it's because when you experience something, when you go through it, you know how to write about it. You know what caveats there are. I'll give you, this is not a fun example, but a bad example of one. There was a student that I had spoken to from a med school in the South, and she was trying to get a very similar accommodation to me, coming in and out of the OR with something to sit on. But her disability resource advocate, no one around her, was actually communicating with the OR, and the OR was insisting that they sterilize it every single time, which is insane. You don't sterilize your glasses. You don't sterilize your scrubs. You don't go, oh, well, I guess my scrubs are non-sterile. I gotta, that would require constant changing every time you come out of the room. So like, I was like, well, you gotta work with someone to figure this out. And I don't think I would have, without having that experience of doing it, I wouldn't have been able to help her with the language of her statement to the OR facilities people, to be like, this is, what she said in a much nicer way, but this is ridiculous. This is absurd. You don't require such stringent things for other tools that we use. Those the headlights that surgeons use, they're not sterilized. I've seen it. Everybody, they're not. Anyway.
Okay, I think Pepper and I were playing unmute chicken for a second there. Um, I think the other thing is that we exist at the intersection of all of the conversations. So there's the DRPs, there's faculty, there's everybody. We exist at the intersection of all of it, and then we road test it. And then also in all of that, we are the people with the least power. So we are coming into all of these situations with the most lived experience, the least power, and then the most time spent trying to implement all of this. And so I think it's not to say that our insight is the most important, but I think that's not the case. But I think it is an essential part of anything like this. And I also think it's in keeping with the disability rights slogan, "Nothing about us without us," to make an accommodations guide for medical students without disabled medical students would not be best practices.
Completely agree with that, Nora. But also on top of that, as a medical student, especially relative to, for example, like the faculty are often very familiar with things in their department or their rotation. As a medical student, you can see across all the different rotations that you have been on, or with your peers, and that can also be very valuable in understanding how things are different between the different rotations and being able to bring that perspective of, oh, if you only had the faculty from these departments, you would miss out on the things that students might need in certain other rotations or certain things that one group can learn from another. And so being able to have that wider experience across different specialties can be valuable. And also that experience of having to keep changing between specialties all year long. And does that tell you, bring anything else to the picture? And as the others have also talked about, to some of those day-to-day practicalities that we had to work into some of the accommodations. Some, as we said, it gets a little sad sometimes, things like having accommodations to be able to just take a 10-minute break at some point in your day. That could be an accommodation, and it's a little wild that that's the case. But I somewhat doubt that if that student voice hadn't been in the process, that these are the kinds of things that people would think of.
Yeah, very true. I think that uh, that comment about how the structure of medicine necessitates asking for things that would not be normal to ask for in other contexts really makes sense. Um, okay, I do have one final question to ask of you, and it's about how to apply the accommodations guide that you helped co-create. Um, how would you recommend the guide be used by students and then faculty and administrators?
I think as students, we are often asked what we need. And sometimes it's hard to imagine what we might need. We've talked about this a lot. And, there are people like Pepper who've had a wonderful chance to shadow and to spend time in those clinical environments in advance. That may not be possible. For instance, for me, I went to a satellite campus in a different state for my clinical years. So even if I'd wanted to during my preclinical years, it would not have been possible for me to tour my clinical sites. I think that a guide like this can allow for that self-reflection where you can read through it and say, you know what? I never thought of this scenario, but I think that accommodation would look good for me. Or, ooh, I didn't realize this would be a thing somebody would ask me to do. I don't think this is right for me, but maybe I can use this as inspiration to think of something that is. And you can bring it to your disability resource professional, you can bring it to your admin, you can bring it to whoever and say, hi, I have this resource from this known trusted source. I've read it, I've taken this, this, and this from it. Here's what I think I need. Here's how I think this could be a little different. How do we go about making it real? And hopefully they'll know about it as well. If not, it's a good opportunity to share. But I think we all have the experience of being a self-advocate. And I think documents like this, as well as communities of other disabled medical students, and the inherent knowledge and wisdom that comes in being in disability communities, can allow us to have that reflection and that knowledge to bring to the people who can help us access these spaces.
Yeah, and then building on top of that, it's not just that process of figuring out what might I need, what might I be able to ask for, but also, as we've alluded to, there's also the implementation process. And, we've talked about it mostly in the context of kind of were they able to implement it or they not? But there's also that step in the between of did the person who needs to implement my accommodation understand what was being asked for? And sometimes that can be an issue too. When I first asked for accommodations, the person clearly didn't quite get what I was trying to convey. And so having a more standardized set of language would be very helpful, especially over time as people become more familiar with it, to be able to clearly convey to the people implementing these accommodations what the student needs so that things can be achieved in a timely manner.
And I guess to kind of, I'm not an administrator, but to speak to what administrators could do, um, and something that I found, this is just an example of what would have helped, me personally, is if I had had a presentation about this guide. It doesn't have to be specifically this guide, but even if you take pieces of the guide and you say, here's some examples, yes, like you could go read it as a student, but was I going to read it? No, I have other things to do. And I actually, this is a funny aside, I had no classroom accommodations until my very last semester, not because I didn't qualify for them, because I didn't know that I just had no idea until if I had spoken to, or if they gave us a presentation, if some admin gave us a presentation and said, here, this is what disability is. These are the kinds of things that can be done. These are the kinds of things we've done in the past. I probably would have, had a much nicer time because, I had issues in the classroom. So, yeah.
Well, thank you very much for allowing me to pick your brain. We do have a few audience questions that I think would be helpful to a lot of people. Um, there is one person who asked, and they're speaking from the lens of being a surgery resident. Um, they were wondering if you could talk about some ways to better support trainees with new disabilities. And they were thinking both from the GME and near peer perspective.
That ties a little bit into some of the things that we alluded to before around like limitations for us. As far as I'm aware, for this group, predominantly our experiences are of people who had disabilities coming in, whether they were identified or not at that point in time. But I have had experiences of talking with people who have had the experience of developing a disability or acquiring a disability during training, whether that was in medical school, residency, etc. And I think it sort of magnifies some of the issue that Zach was just talking about. Even among those of us who come into this knowing that we have some kind of disability, it can be hard to find the information and to be kind of aware. And I would expect from my colleagues for whom this is not at all on their radar, like none of them are going to have gone and found everything ahead of time. So I think from an admin perspective of making sure this information is being repeatedly presented to your trainees so that at any point even those who maybe weren't paying attention too much before could at least remember that it got mentioned at some point and that there is something, even if they don't remember what it is, that they know there's something there, or that it gets brought up again later and someone can go, oh, I need that now. So I think that is one really important piece is making sure this information is being like not just available, but presented repeatedly and early. Um, to everyone. It shouldn't be necessarily require people to have to opt in to find out about these things. And then also to ideally reduce that feeling people often have of being very alone. Because again, if you weren't looking for it before, you probably are not aware that there is community around being disabled in medicine. I know, for example, at my current institution, there's a associate resource group for disability for employees kind of in general, not just residency specific. Um, and so I think building that piece could be very potentially very useful for somebody who is having to navigate a lot of this for the first time while also trying to handle, continuing in their training or taking a break from their training in order to manage a whole bunch of other changes in their life all at once.
I think I'm gonna I everything I 100% agree with. I was trying to summarize in my mind like the main things. So community, you need community of like-minded people. You need an institutional advocate, whether that's your PD or APD, someone who you don't have to disclose, but at least explain that you might need a reasonable accommodation. Um, and then the last one, which kind of it depends. On what the requirements of your institution are, but you need a physician that you really, that can help you craft language. My PCP, I send him a letter. He knows all my stuff. I've been with him since the start of med school, and he just says, "Okay, let me read it, sign it. Okay, great." Those are the three main things I would do. If I did, community institutional advocate who can help you craft if you want to stay in your specialty a reasonable accommodation if that's possible, and then something else if it's not, and then a physician. Those are the three. I don't know, Nora, do you have anything? I mean, there's probably more, but those are like
The thing that I was thinking of more from a systems perspective and a like a GME side of things is remembering what the EPAs are, remembering what your actual and trustable professional activities are. Because I think sometimes we get very caught up in the this is the way we do it, and this is our EPA, and this is the only way for you to meet our EPA. And if you can't do it like this, then you cannot meet the goals of the program, and therefore you cannot graduate, or you cannot be boarded, or you cannot do whatever. And I think that's rarely the case. And I think sometimes um, it holds people up. And it also is a thing to think about if you get an accommodation that's denied. I know it's not what we're talking about here, but it comes up very frequently where nights is a very common one, or work hour restrictions are a very common one where a person asks for something and they go, and the school or the program goes, oh, we can't accommodate that. And then you get stopped in your tracks. And I think sometimes the way to go back about that or to work through all of these things is to say, what is it that I need that specifically needs to be addressed? And what is the EPA that they're trying to make sure I meet? And how can I make my need met while still meeting my EPA? If the goal of nights is to work in a lower, like it is to work in a hospital with a skeleton crew, essentially, because sometimes that's what it is. It's to act like you are, learning to be a junior, like going from a junior to a senior. Perhaps you work more weekends. Or perhaps the issue is the 24s. Maybe you could do night float instead, and there would still be coverage. And so I think going about it in a way where you're making sure that your needs are met and the program is knowing that you're there and that you're part of the team and that you're there to meet your EPAs and be a good doctor, which they should know. They hired you if it's GME. But for all of it, I think that's an important thing that we need to make sure we're coming back to and is a good place to go back to in all these conversations.
Thank you all. I have another question here, and it might be kind of a shorter answer, but this person is asking, how long do you wait for your DRP to figure out a clinical accommodations or a clinical accommodation you request? So, and then they ask for specific timelines, like before you start clinical rotations or requesting during clinical rotations.
I talked earlier about starting early, and honestly, I would reach out as soon as you think Reach out to them as soon as you think that you might need accommodations and that you're going to be at that institution. If that's before you get there, then that's before you get there. Um, as for the more specific accommodation pieces in terms of what you're going to need, again, I would start the conversation as soon as you have an idea about what it is you might need. Um, and that's going to vary. Um, it's not uncommon for people to have a process where it can take months from when you talk to your DRP until you have that letter in hand. And even then, implementation can be a whole nother process. Um, Granted, sometimes that's not feasible. Sometimes you don't realize that you have this particular need, whether that's because, you learn something new about what's to be expected of you, what's being expected of you changes. Programs can change. They may change clinical sites, they may change requirements, these things happen. Or maybe what you need changes. You acquire a new condition, your condition evolves in a certain way. These things can, and it's sometimes that happens. And in that case, as soon as your situation changes, reach out. You can never be too early. Um, and more time is always helpful.
To go off that a little bit and to clarify or to talk more about it, the end goal of this process with your DRP is not to get a letter. It's for you to successfully complete your program. And so you should reach out early and you should reach out often to get what you need. But if something comes up and you realize that what you have isn't working, that that lifeline still exists. And you should reach out to them. And you should also reach out to, if appropriate, clinical leadership or whoever your allies are. Again, going back to the idea of allies, to make sure that as you go into these clinical environments, which are highly variable, which which can look nothing like what you imagined, that as you realize that things need to be tweaked or, you know, burned down to the ground and restarted, um, that you have your team and you can go back to them, and that's okay.
Yeah, my first wasn't my final. So I second everything that they said, and um yeah, start early because it's going to be an iterative process, and I hope that they're responsive. And if they're not, you got to find the allies, like Nora said.
And there are emergency accommodations. I will say that if something dramatically changes quickly, you can sometimes get an accommodation approved before your documentation is in, if there is an assumption that it will be approved. An example of this is if somebody, breaks a limb, like has a fracture and needs to now have different parking or needs to now have a different accommodation in a site. Something like that is presumed that it will be accepted and therefore can be approved very quickly. So just because, that isn't you didn't break your arm. If you get into a site and you realize very quickly that something's not working for you or you have a newly diagnosed disability, even if you're already in it, I highly encourage still reaching out because it may still be able to happen quickly and the documentation will just catch up later.
Yeah, and not sometimes you will have needs that are going to be met by other means. I had something else come up in life during clinical years that ended up being handled more through the student affairs office because it wasn't a disability related thing on my part, but some of the things that ended up being needed are some of the same things that might have been needed if someone had had a significant and sudden change in their disability. That again, there's other avenues that will be able to get you things quicker um, that may or may not be applicable depending on your situation.
Yeah, that was a very in-depth response. It was silly of me to say that the answer would be short. Um, I think we have time for maybe one more question. Um, and so what's next on the list is a question that says, hearing everybody's story about the successes and failings of seeking accommodation in the medical field, I wonder if this guide of accommodations could act as a starting point for all professional fields and accommodating professionals with disabilities. So what would it take to get more people to look at this guide? And I think they're talking about across the health professions to start making changes.
The cause needs champions. It needs people with a seat at the table that can bring it up. I mean, and there are wonderful interprofessional organizations that can help do that. Um, and, talk about it at conferences, share it with your friends, share it with your disability circles. But yes, I see that comment, accreditation bodies. Absolutely. Um, that is a good way to do it. But also, um, course leadership as well. If there's anything that's like an IPE event that's related, or you happen to know anybody, you happen to work with anybody, that's another way to do it. But at the end of the day, it takes somebody with power that cares. And you just need to get it to them and make them care.
I guess that was Zach, did you have anything to add?
I think as long as I didn't know if it meant professionals like in healthcare, professionals in general. I think that healthcare is the one of the largest frontiers where this is necessary. But all professions as well. But yeah, I think interdisciplinary like professional groups. I remember when we were in MSDCI, we were talking with I think there was a law student group that we had spoken with. So that was um, something that I think is necessary. I also think like the labor side of this is another avenue that you can go by. The people that are in power, during contract negotiations, Jefferson is negotiating a contract. No, it's not finished yet. Yes, I wish that I was more involved in that process because then I could say, hey, part of this maybe we could have like some sort of language in there for accommodations, some sort of review board that includes residents, so stuff like that. I think there's a um, with the tons of residency union drives across the country, I think that that's going to hopefully play a role too. But that kind of what Nora was saying, that person in power includes whoever's negotiating that contract, getting to them and saying, hey, this is something that I think is important that we discuss.
Thank you. That I think was a really thoughtful response, especially since it's a hard question to answer, especially if you haven't kind of like where we have only one perspective here, and that's from the learner perspective. And so I appreciate your thoughtful engagement with that. Um, I think this should be the end of the solicited questions. So thank you, all three of you, for coming out here. And also shout out to our captioner and to Zoe, both helping behind the scenes to manage everything smoothly. I have a few final notes to chat about before you all go. Um, First off, we are going to post the recording of this event onto YouTube, and it should hopefully be up in maybe 4-ish weeks. Don't hold me to that exact number, but we will try to get it up as soon as we can. So please feel free to share this video once it's posted with your networks. And then second, I think it's important that if you guys would like to get more information, especially resources from the 4 organizations that participated in this project, I think it might be helpful for me to share with you a little bit more about these organizations, like their contact information. Right. So the organizations are DM3P. So you can email us at info@disabilitymedmentors.org or check out the website, which is disabilitymedmentors.org. For the Docs with Disabilities initiative, go to docswithdisabilities.org. For medical students with disability and chronic illness, go to msdci.org. And then for SMADIE, you can go to med.stanford.edu/SMADIE.html. And I really highly encourage you to go to these different organizations. They have amazing resources. MSDCI, for example, has a guide that was published, and Nora spearheaded that, where it talks a little bit more about how to seek out accommodations, but a bunch of other things that you need to know to make your experience throughout medical school smoother if you happen to have a disability or acquire one during your training. So for resources like that, definitely check out these different organizations' websites. So with that, I'll stop sharing and thank you all so much for coming out here today. I hope this was helpful. Have a great, great evening.